Good evening all. Sorry for the delay because of some technical glitches, but now I think it's okay. So this is the today evening we have a nice session, nice and important session, that is the cancer biology. And we all know that we have we are doing so many things, rehabilitation in pre-operative period, intraoperative period, we are taking care of so many things so that our technique, our management doesn't have any impact on the recurrence, metastasis. So all those things we are always worried. Actually, there is no foolproof evidence whether our technique or management has got any impact really that it causes recurrence or not. But there are many articles are coming up, and all those things are debatable issue. But we all should know that what is the cancer biology, what is the biology of the cells, how they spread, what is the effect of radiotherapy, chemotherapy, that is cancer treatment on the cells, and how they react to the medicine. So everything is very important, and you should have a thorough knowledge before going to a manage the cancer patients. And all these issues will be taken up by now Dr. Rakesh Garg. He doesn't need any introduction. You all know. He is also now present editor of the IJA, and I think this is a favorite subject topic of him. So he will talk on cancer biology now. Rakesh, please join.
Thank you so much, ma'am, and thank you for the words. So we'll be talking about cancer biology. Am I audible, ma'am?
Yes, Rakesh, you're audible. Audible to me, at least.
Okay. Right. So we'll be talking.
What happened? What happened, Ankana?
Sir? Hello?
What happened? I guess slide goes up now.
No, it's an issue from Dr. Garg's side, I think.
Okay.
Is it now okay?
Yes,
yeah,
sir.
It is okay.
Yeah. Thank you so much. So we'll be talking about an important topic of cancer biology, though not much discussed. But in next around 30 to 40 minutes, we'll talk about the various aspects for managing a cancer patients when we talk about the cancer biology, which is a big concerns when we talk about cancer, because now it's an epidemic. The number of patients are increasing, and the cancer burden is expected to increase much more, and almost 20 billion new cancer cases are expected annually in next 2 to 3 years, and that will be a huge burden. And not only this, the deaths are increasing, but number of cases are also increasing. So what we need to do is we need to understand the various aspects of the cancer biology so that we can trap them in multiple aspects, so that the morbidity and mortality because of these cancers can come down. And we also need to understand that the cancer-related or cancer's occurrence and stated death are quite varied, though there are certain changes as compared to the global versus in India. The lung cancers remains one of the common one, the breast cancers remains one of the commonest one. And in addition to this, the presence or the care of these patients are usually delayed into our setup. And hence, when we discuss about its perioperative care or in general, the cancer management, because of the late presentations, late attention, depending upon the various features of the cancer cells and their aggression, their metastatic potential, the management becomes a little issue. And these patients lands up into various aspects. So what we need to understand as anesthesiologists with regards to the cancer biology is that how this cancer presents, and we need to prognosticate them, because though these patients will be coming for curative aspects, but many of the time, because of the advanced disease, the curative intent may not be provided to these patients. It becomes palliative intent, and then we need to prognosticate them. Also, we need to understand that the various cancers histopathology have different potential for its local versus systemic spread, for its aggressiveness, And that's why we need to understand that these cancers of different origin, of different histopathology, needs to be managed with appropriate treatment in a timely fashion. And when we start treating them for these aspects, they would be receiving multidisciplinary management, which is inclusive of the medical oncology, radiation oncology, surgical oncology, in addition to the adjunct specialties like dietitian, physiotherapists, and so on and so forth. And when these treatment are being provided, each of these treatment, though they are beneficial, but they have associated side effect or toxicity profile also. We need to understand them, and why they manifest and what can be done for them is also becomes a part of our management. And this will require a proper planning and proper strategy for the perioperative care also once the surgical procedure. And once we understand this aspect of the cancer biology, probably the outcome becomes much better. Now, starting the first aspect of the cancer occurrence, basically, we have, say, it's a group of more than 100 different diseases, and that is primarily characterized by uncontrolled cellular growth, local tissue invasion, or distant metastasis. So when we talk about the progression of the disease or from a small cellular growth, which is uncontrolled, probably it's a multi-stage process. And it appears that in many of these, there is some genetic regulation or inherent regulation of the cellular multiplication, which becomes uncontrolled in the form of a local invasion or tissue metastasis. The control behind it is primarily, there are two types of suppressor genes, which otherwise normally in the human body also cells are uncontrolled multiplying it. And the tumor system, body controls or phagocytic abnormal cells, which are abnormally multiplying it. And that's why the process that's going on will not be get cancer. Protective mechanism inside the body itself, which is genetically controlled. And that's why each cell will not become a malignant cell. And when this happens, if you see the natural history of this cancer as such, so once somebody has either a genetic phenomena or somebody has some factors which are responsible or which are carcinogens, the patient will be exposed to them. And under the influence of these either carcinogens or genetic phenomena or some precipitating factors, there will be an onset of disease. There will be small cells which starts multiplying. As I mentioned earlier, majority of times patient is able to engulf or phagocytize those cells, identify those cells, and they prevent them for further progressions. And probably this is a preclinical phase, or you can say a preventive phase can also be attributed at this time. And that's why majority of the genetic screening programs are identifying these type of high-risk patients to identify the biological phase of these patients. And sometimes the prophylactic surgical procedures are being done in these patients before they manifest as cancer. And this preclinical phase, subsequently, if it becomes uncontrolled by the body, they are bypass the patient's body preventive strategies or mitigating strategies. They becomes into a clinical phase where they will have certain symptoms, and then or by
Excuse me,
some
Rakesh.
interventions they can have.
Sorry, Rakesh, 1 minute. Delegates cannot hear anything. They cannot see the screen at all. So, Ankana, they have to do something actually. You have to start again because everybody is asking. They cannot join. They cannot see anything. They cannot listen anything.
Okay, so then, ma'am, I have to check it once again, ma'am.
Yeah, please do that because all the delegates are writing
Sure,
the
ma'am.
same thing.
Sure, ma'am.
That's why I wrote to you on the message also. Please recheck and send the link again to everybody.
Okay, ma'am, I'm looking into it. From our end, it is done, but I'm looking into it. What is
No
happening?
delegates is able to see or listen anything.
Okay, ma'am, kindly give me some time. I'm looking into it.
Please. Rakesh, you have to start once again, I think.
Sure, ma'am. No issue, ma'am.
Jyotsna Raki here. Even through the Clarinet link, you cannot see anything even in my mobile. That's why when you gave the Zoom link, I can log in through that and I can see that. But through the
Okay.
clarinet page, you can see nothing. It is still shows that it is
Yeah,
yet to stream.
that's what I
Yes.
told them. Everybody is writing in the group. Please see that.
And people are mentioning that
No.
Because Dr. Garg, what is happening is when you go through the clarinet site and you type your number in which already registered, it goes on and on and on, but it never opens. And after 10 attempts, if it opens, it says that the streaming has not yet started. So that is why
there is some issues with the
Zoom site I can clear through the clarinet.
There were issues of linking the Zoom for the
They
live
can give
telecast.
the Zoom link directly to them, no? Not through Clarinet.
No, I think somebody has uploaded the link in the Zoom because I have not gone through that link. I did not get any link, Zoom link before. I just got it now in the SOPSI official group.
No, this is the faculty link. So delegate link nobody is able to see. So Clarinet has to do this something, otherwise it's difficult.
Shall I just core committee to the SOPSI official?
I just asked the Clarinet people. I don't know for what reason.
Oh, okay. Oh.
That if this faculty can join directly.
Bolo. Rakesh,
Yes, ma'am.
Anjali is sharing the faculty link to the so that we'll check here when everybody is joining after say 30 or so, then we will restart again from the beginning.
Sure, ma'am. Sure.
Okay. So we'll just check in because joining through the same link.
Okay, ma'am. Maybe if you want, should we reschedule it?
No, let it finish. Let everybody join.
Okay.
And
Yes, people are quickly joining from 13 people. Yeah, so just
Uh-huh. So, I think Rakesh, you can start now,
Yeah, whatever you say, ma'am.
or wait for 30 people, as Anjali said. 30 will rejoin.
Sure, ma'am.
I think you can start now, no?
ठीक है, ma'am.
So, Dr. Rakesh Garg will start the thing. Sorry for the connectivity issue. Dr. Rakesh Garg will restart from the beginning again. Okay, Rakesh, start.
Thank you. Yeah, thank you so much, ma'am. So today we'll be talking about the cancer biology. It's an important aspect when we want to provide a holistic. The number of cases are increasing. It is bypass.
Some question. What happened, Ankana? Please.
Dr. Garg, sir?
Let he has started. Let him start now. Nothing. No
Yes,
more
sir.
introduction.
Yes, sir.
Rakesh started only. Let him go on, please.
Is the skin visible now?
Yes.
Right. I think some network issue. So okay.
Hmm.
So the cancer is becoming an epidemic because the number of cases are increasing.
I think Dr. Rakesh, sir, is facing some network glitches from his end.
Rakesh is a problem or from your
Yes,
side?
yes, ma'am. No, no. It's the technical glitch from Dr. Rakesh sir side.
Rakesh,
I think Jyotsna ji, he has left. I think he will rejoin.
okay, okay, fine. Lot of technical problem actually.
It's a live session now,
Related
ma'am.
to the
The people
earthquake.
can see from live only.
Is it due to the earthquake that all these technical issues are happening?
Don't know, ma'am. We have no clue. We are facing the same.
We can use Google or Zoom something. We'll try something else next time. Because
Yeah, I
lot of
think we'll
time,
try some Google Meet or something because
yeah,
yeah,
because a lot of time is wasted, no?
yeah, and I think with the other platform, Zoom, we have a time restriction. Google Meet, I think, might be better. We have
Better, better.
26 participants now. I think we can start.
Yeah, some Rakesh is not there right now, till now?
Oh,
What?
Yeah, join now, join now.
Okay, okay, please.
I think some network issue is happening today.
Yeah, maybe
Oh.
due to the post-earthquake.
Yeah, screen visible, ma'am.
Yeah, it is visible now.
So sorry for the technical glitches happening from multiple sources. We hope next half an hour should be okay. So we'll be talking an important topic of cancer biology, which is one of the very basic aspect of managing a patient who comes to cancer. If we can understand the nitty-gritties, what is happening at the biological level of these patients, probably we will be able to provide better care to these patients, from holistic care to these patients. We all know that cancer is becoming an epidemic. The number of cases are increasing, almost 20 million as early as 2025, and this will create a lot of burden on it. And this increased incidence of cancer is also leading to increased amount of mortality, because of which almost 50 to 60% mortality is there seen in these patients. And especially in developing countries like India, where late presentation of leads to more aspect of these are advanced cancer patients then. And that's why we need to understand the cancer biology from multiple perspectives for curative, for palliative intent, for it. Understand even the site of tumors in these patients, so that we can provide some holistic care to these patients, understand those issues, and probably provide prognostication accordingly also becomes important. And we know that the most deadly cancers remains the lung cancers, the breast cancers, which are the commoner one. The oral cancers, again, these are the commoner cancers which are commonly seen into our. Why do we need to understand? Because once we understand the behavior of cancer cells, it becomes easy for us to understand the cancer and its presentation also. Also, we need to understand that these patients would require certain management, which is usually multidisciplinary for majority of these cancers. And there is a undergo a specific therapy. Otherwise, some of the cancers are too invasive, they grow too fast, and then they becomes metastatic locally or metastatic. Also, when of these treatment do have some impact on the other healthy cells also. And these also needs to be understood at what type of changes happens inside the body, so that we can assess them properly, plan a proper management if they are posted for surgical procedure. And then the perioperative care itself on the cancers. Protective, some are inhibitory, and some promote the cancer recurrence or cancer metastasis, though they are in initial evidence is emerging. They are just an hypothesis. We do not know very sure. So next around half an hour or so, we'll try to discuss those aspects. We know that cancer is basically the uncontrolled, can lead to the breach of the organ in which it is proliferating, leading to local invasion and then distant metastasis. Basically, this is a multi-stage process. Each cancer cell probably are emerging from the organs at variable stages in But all cancers do not become cells do not become cancers because body has its own inhibitory mechanism, which are known for the cancer. They phagocytize those cells, they identify those cells, lead to the further proliferation. Background on it, and if we talk about the two major classes of genes which are involved in carcinogenesis, oncogenes and tumor suppressor genes, which are important aspects. When we understand this biology, how the cancer goes, I just mentioned that there will be some uncontrolled, but the preventive strategies are inherent to the body. This controlling body phenomena or they control and they progress from preclinical phase to a overtly manifested cancer that may be detected as early detection for subsequent management using imaging by examination. They respond to therapies or they do not to therapies, and so this is a natural. There will be some aspect of cancer biology will help us to manage these patients better with regards to providing them either a cure or a palliation with prognostication, and that is what is required. Now, I was talking about the genetic and molecular basis of the cancer, the oncogenes which develop from normal genes called proto-oncogenes. And if there is any alteration or any mutation that happens in these, they can be activated, and that becomes one of the genetic phenomena for the occurrence of cancer. If you talk about tumor suppressor genes, inappropriate cellular growth, and there are certain genes like retinoblastoma gene, P50 genes. If anything happens to this, happens, and that sometimes this uncontrolled, the loss of control, basic occurrence of cancer in these patients. And this genetic phenomena, various other carcinogenic externally, like HPV. So these are all can be altered by these external mechanisms. And these, when we talk about these environmental or external factors, they could be like tobacco, they could be like smoking, they could be like UV light, which are responsible for oral, lung, and skin cancers. And there could be many now well-identified infections, like for which are responsible for, say, hepatocellular carcinoma with hepatitis B, HPV-related for cervical cancer, HPV for anal cancer, Epstein-Barr virus for buckets, for nasopharyngeal cancers, and even the martomas for Helicobacter pylori. So this means there will be some relation between the various aspects, like genetic, which are influenced by environmental risk, and an independent of some infective pathology, especially the viral infections, which are responsible for the carcinogenesis. And these are having some of the things has been very well proven. Look, for example, say breast, BRCA1 and 2, or smoking, HPV, cervical cancer. So there is relation of factor for or the occurrence of cancer. Now, when we talk about pathology, because this carcinogen, I usually say divide them as benign or malignant, subsequently classified as anti-hematopoietic. The biology is different, and the genetic and which I've just mentioned, their towards the body is also different. So the tumor invade and destroy the surrounding tissues. These cells are genetically unstable. They have loss of normal cell architecture. The usual function, and consequently recurrence are because they have already lost control from the biological aspect, from the inherent genetic changes that these cells have, and that leads to more of a recurrence. And these are important when we need to provide them care. And also we need to understand that the two primary pathways of metastasis are either hematogenous or lymphatic, in addition to the local infiltration. And that's why different type of cancers with different histopathology, even if they're from same organs, will behave in a very diverse patterns. And that's why the biology becomes very important to understand, which remains even extant for many of them. Sometimes these cancers tumor mass cannot be detected by physical examinations or radiological studies when they're too small, and hence it becomes very, very important for the early detection and not to avoid any symptoms that's even these small tumors, because if we can detect them earlier, the treatment modalities are available, the cure rate is much higher. The 1 centimeter mass weighs about 1 gram and contains about 1 billion cells. And now you can imagine that it requires approximately 30 division times for a tumor to grow from 1 cell to 1 billion cells. So this means the amount of division that is required for these patients will be too fast and depends upon the organs, depends upon the histopathology. And based on this, we plan our treatment. And when we plan our treatment, the goals are basically to cure the patients, make them clinically as well as pathological free of disease, and we do have various options. And sometimes when they are, this is not possible, then we try to maintain them the functional status and maintain them the quality of life by providing them symptom relief. And sometimes the prolongation of life is not feasible, but yes, the quality improvement in their life becomes important. And for this, we use the multidisciplinary approach for these patients, which requires surgery, radiation, chemotherapy, and nowadays even the biological therapies which are available. But these therapies would depend upon the underlying biology of these patients, underlying disease progression of these patients, underlying extent of these patients, whether they are at a particular tissues, they have breached the anatomical area, they are metastatic, and on the other hand, most technology has improved. To some amount of ability of the, and once they start certain for given for with regards to various though it's is even more focused now with more advanced into the radiation oncology suits, but then still various areas like the anatomic areas, tissue sensitive with regards to pathology, the dose, the cumulative dose, the concomitant treatment, associated patients' comorbidities will decide that what type of toxicity profile he has and how much he will be able to tolerate. So this was one aspect when we say that we want to give chemotherapy and radiotherapy to these patients, but depending on factors, genetic carcinogenesis, and subsequently, we need to understand how these patients will be toxic or reduce the of these, but then the effect comes down. The second aspect, which is important, is I mentioned that we were talking about the doubling time of the cancer cells, and hence it becomes very, very important for timely action. With regards to the chemotherapy and radiotherapy, it should be given at the earliest, but when they're being worked up for the surgical procedures, they need to be optimized. And nowadays we use more of a term like prehabilitation, And then this rehabilitation is given to these patients so that they can tolerate the major surgical procedures better, so that they have a better outcome with regards to the quality also. The majority of these procedures are not emergency or urgency. They have been put into time-sensitive surgeries because they cannot be elective also. They have to be done earlier. It's where and that's why part of the cancer will involve, as I mentioned earlier, also the genetic phenomena, which is predominantly affected by various inherent cancer-producing cells, and they're also affected by the external factors. And this all needs to be taken care of when we are managing these patients. And that's why sometimes these various genetic alterations that are happening, we at times use certain agents which will be affected by the various external factors like EGF. Certain of the tumor cells. Sometimes we have to use certain agents so that once we understand this biology whole, the giving specific individualized medicine is become more commoner, and these patients are able to be getting managed appropriately. Simultaneously, we also need to understand other aspects of the biology here. Now, sometimes say some cells, especially the highly proliferating cancer cells, they will be resistant. They may be having genomic instability. They may be activating invading factors which will invade the areas, the anatomical areas, and leads to local invasion, or at times, in addition to angiogenesis, there could be a distance metastasis. There could be inflammatory process also. That is because of the release of various factors from the tumor cells. So this means there are many things which are happening because of the presence of the abnormal cancer cells, and those needs to be understood for giving them a so that the facilities are available now. These under available now, and that's why we are able to give them more. But sometimes the care give to these patients will spread up, and the cascade will happen. And the cascade is usually area. They breach the anatomical layer, and that leads to intravagination. So as I usually have concept of the phenomena or a lymphatic or distance area, and I just mentioned the phenomenon and inflammation that happens, that facilitates the tumor cells getting rid of from their origin areas to go into the intravascular areas, and then they migrate, and then they settle down into various draining areas, and that becomes a cluster of cells which further proliferates, and that leads to the metastasis and organ dysfunction subsequently. So this is what I just mentioned to summarize again for you, that when we have a primary tumor at a particular site, there will be certain changes that will be happening. The tumor cells will proliferate. They will secrete certain inflammatory markers or cytokines and prostaglandins that leads to angiogenesis and breach of the encasing area. They detach, invade, and they embolize to either to vascular areas or lymphatic areas, or arrested into various areas, or they sometimes adhere to the wall and invade and have a microenvironment which further proliferates in the area in which they have arrested, leading to organ dysfunction. So this is how the tumor areas happen, and the various factors are involved for tumor evasion strategies, which are related to these various cytokines, various prostaglandins, various inhibitors, and that leads to the occurrence of local invasion versus metastasis. All factors which I've just mentioned about the the biological aspect. They're all influenced by factors that we provide them into the perioperative care also. So one, we have talked about the inherent factors of the patient himself, which are genetically or carcinogenetic phenomena that are leading to the aggressive disease and spread. But there will be some factors which, as anesthesia involved, which will influence these factors either by suppressing them or by elevating them, and the chances of the patient's outcome is altered. And these are the various factors that has come into the evidence, like the surgery itself, the presence of hypothermia, the stress, including the psychological stress, the appropriate choice of the drugs like intravenous agents, inhalation agents, use of opiates like morphine, the regional anesthesia technique, especially using the local anesthetic agent, the blood transfusion versus anemia, the pain itself, the use of COX inhibitors, and certain other drugs like beta blockers, etc. Now, they all have a potential progression, and hence the interplay external versus the patient's inherent capacity to materials by the cancer cells, and that can lead to the stresses in the which I just mentioned. When we talk about the surgical tumor, also this means what are the factors? Because when the surgical tumor manipulation, there will be a lot of response happening. One is the stress response, which at times able to manage it, but that stress response itself suppresses a lot amount of the body inherent phagocytosis activity, and some amount of tissue, some amount of cancer cells which are released into the body will not be phagocytized, and there will be chance of getting sitting of these cells into different organ systems leading to metastasis. In addition to it, the surgical tumor manipulation also leads to the endothelial disruption, local seedling or thoracic cavity or intraperitoneal seedling, the enhanced inflammatory response, the tissue hypoxia, the hypothalamic pituitary adrenal axis suppressions, and these all lead to some changes, maybe the spread of cells through the various lymphatic or vascular routes, the transcelomic spread, the release of factors, cytokines, growth factor, prostaglandin influence the capture of these cells released into the body systems, immune suppression that happens, tissue hypoxia related HIF and VGF factors that are released, the hormonal mediators that are changed because of suppression, milieu for the metastasis. Similarly, anesthetic related factors like the use of NSAIDs or the opiate antagonist, they also have a suppressive response factors that can lead to cancer metastasis. Agents or the suppression of the immune system, they promote the cancer influence on that we have just discussed, which are protective for the cancer, and they are suppressed, and that's why it leads to the release of cancer cells into organs, further proliferation, and thus the metastasis, the local invasion. And there are sufficient studies and evidence which are emerging as late at 10 to 12 years back. This was one of the earliest paper which was published as an editorial, where they mentioned that the cancer biology, the analgesics, and the anesthetic is there a link. And in this paper, the Buggy et al. And his team suggested that, yes, there are certain factors which appears, they influence the cancer biology, and then there is a potential that these cancer cells, which otherwise are localized initially, but in the perioperative care, a normal patient's physiology leading to the and thus there are chances of the metastasis in these. And then subsequently, papers started coming up. The phenomena. Paper published around some study the effect, invasion, and apoptosis of the and they found that they compared this found that the patients various markers, they found that those patients who were receiving the regional technique, they proliferations and invasions of the as generated in vitro. And so that's why they said the anaesthetic technique might influence the way that affects the cancer by human metastasis, and they were of the view that technique here is more of a protective phenomenon for general anesthesia, probably general anesthesia less influence on of, and this was subsequently this nice article around 2-3 years back, where they mentioned that the comparison of the general anesthesia versus regional anesthesia technique, they have influence on the various aspects of the body physiology, which are responsible for the tumor progression. So when say that in the perioperative period, when the surgical resection is happening, there will be some amount of tissue damage. Now, if the regional anesthesia has been given up, they will have effect on two major aspects. One, the surgical stress response and a better pain control. The better pain control, pain, we know that it leads to immune suppressions. The various markers are affected, and that can lead to disease recurrence. So this pain can itself be better controlled by regional techniques. And nowadays we have various regional techniques, local anesthetic-based regional techniques, which have a better influence, and thus the chance of recurrence probably becomes lesser. Also, it leads to a decreased amount of surgical stress response. This is well known. This leads to lesser suppression of HPA axis, and this leads to the change in the various catecholamine and cortisol levels, which have direct tumor effects. And that's why the chances, if they are suppressed, this will have a better chance of the prevention of the cancer recurrence. Similarly, when the tumor hypoxia happens, which can be there if the patient is having hyperperfusion, major blood loss, because of the impact of various anesthetic technique, this tissue hypoxia can lead to angiogenesis, which releases certain factors like IHI, the hypoxic inducible factor, and VEGF, which can lead to more angiogenetic phenomena, both vascular and lymphatics, and that can again lead to disease recurrence. So this means these multiple factors which are responsible for cancer recurrence are affected by our technique itself. And hence, we need to look for various agents that can be looked for. At certain, the regional anesthesia itself is affected, and in certain aspects, even the local anesthetic agents has been found to be useful, because we know that inflammation leads to the secretion of various prostaglandins, which are direct tumor proliferating effects, and this can be easily blocked by anti-inflammatory actions of the local anesthetic agents. So this means we have to have an individualized approach using appropriate drugs, which appears to be protective. We don't have a robust evidence as of now, but yes, we can easily say that regional anesthesia is hypothesized to reduce cancer recurrence by reducing the surgical stress and the associated immune suppression. It also reduces the volatile anesthesia and reduce postoperative pain and opiate requirement. And all these three factors have been found to increase the cancer recurrence. Probably local anesthetic agents like the bupivacaine specifically and the lignocaine infusions also, they also have been found to have direct anti-tumor effect. The reports are conflicting, but still the directionality of the protective mechanism of the regional block is favoring preventing the cancer recurrence as compared to the general anesthesia techniques. So what we need more robust studies which are ongoing. We may need to wait for a couple of years to have a robust evidence that which is the best perioperative technique that will bring down the chances of recurrence by our cancer, by our various strategies or various drugs that we use in the perioperative period. Now, this is another interesting cell working on the cancer biology, where they have studied the effect of anesthetic technique on natural killer cells, which has an anti-tumor activity in patients undergoing breast cancer surgeries. And they found that those patients, those females who were going the surgical excision with the regional technique has a better chance of survival as compared to the general anesthesia with less chances of recurrence. Similarly, in other studies where they were looking for the apoptosis, because we know that during the surgical procedure, There will be some release of some cells from the tumor area during the surgical procedure because there will be tumor, there will be tissue damage, there will be vascular damage, there will be seeding sometimes. And hence we need to require that the protective phenomena of apoptosis should be maintained. And in this study, in this in vitro study, a pilot study, they found that the serum from patients who were giving general anesthesia, including sevoflurane along with opiates for the breast cancer surgeries, has reduced the apoptosis in patients as compared to those patients who have received the regional anesthesia technique. In this case, they have used the paravertebral anesthesia along with propofol sedation. So this means probably the effect on various secretory materials, the preventive strategies, the apoptotic phenomena, they're influenced by the perioperative technique. Not only this, the drugs like midazolam, benzodiazepines, the dexmedetomidine, they also affect this cell biology, and there are studies which has come up in vitro and vivo. And they found that the dexmedetomidine reduces the cellular apoptosis, and the phenomena of the midazolam also was in pro-apoptotic effect, and they can reduce cancer cell survival. So this protective phenomena of these drugs was studied in vitro and vivo, and they found that dexmedetomidine enhanced the cancer cell proliferation and migration primarily by upregulation of the anti-apoptotic proteins. On the other aspect, midazolam suppressed the cancer cell proliferation and migration, induced mitochondrial mediated apoptosis, and enhanced free radical production. And these anti-cancer effects of the midazolam by its effect on the peripheral benzodiazepine receptors, but they were achieved when the drugs, the concentration, the dose they were using very high, which is not practically used. So probably they have the protective mechanism. Midazolam has some impact on the apoptotic phenomena, leading to decreased chances of the cancer metastasis, but the doses required are too high and maybe the clinically applicability is not much, and we need to have more data for it. We talk about the another good paper where they have talked about the impact of anesthetic technique upon outcome in oncosurgical procedures, and they have mentioned it very clearly that during the early cancer or when the cancer is being operated, the tumor development will depend upon multiple factors. And these factors are influenced by the various things that we do in the perioperative period, including from both aspects, the surgical intervention and the anesthesia. And the phenomena that we mentioned in the earlier paper, also the inflammation, the immunosuppression, the hypoxia, the release of various growth factors, and the phenomena of angiogenesis that can be arising because of the cellular insult. The residual tumor that has developed, if these all phenomena are not taken care of, they will allow them to proliferate further. And the chances if a small residual tumor, which otherwise the body would have taken care of itself, will not be taken care of, and there will be chances of either a local recurrence or metastasis. And that is what we need to incorporate. And we need probably the occurrence of metastasis and of the protective mechanism, local based TIVA, the use of acids has been found to operate that they reduce the surgical on immunosuppression, inflammation, angiogenesis, and growth factors, and hence they are probably protective as compared to all agents able to obtain these phenomena so effectively, and hence there is a possibility of growth of residual cancer cells, and it creates basically a pro-metastatic milieu from which the cancer can spread up subsequently by various angiogenesis or lymphatic phenomena. So this is what we need to understand, that the perioperative period is crucial for patients. Various perioperative interventions may affect the outcome of any patients. The surgical stress produces an environment which is pro-milieu for cancer recurrence. Though there are certain protective mechanisms that have been identified, like propofol-based TIVA, local anesthetics like lignocaine infusion, the regional anesthetic techniques appears to be protective, but still we need more bigger studies which are ongoing, and the data is. Another study which effect of various agents, the effect of propofol and sevoflurane on cancer cells, killer cells, cytotoxic T lymphocyte, breast cancer surgeries, and that the propofol-based effect on the cell. Propofol-based anesthesia is more protective as compared to volatile visible field anesthesia and these type of surgical procedures, and hence appears to be more protective. Another paper where they have recent anesthesia techniques where they have specifically the effect of not only the regional effect, impact on immune suppression, but the use of local anesthetic agents. And they have found that this local anesthetic agents has effect on various aspects. When activity, the inflammatory mediators, which leads to cancer-related inflammation, they are better protected by the use, including a couple of studies in these patients are more protected. So probably, if we can summarize what we have discussed coming into various evidences, that probably these anesthesia and analgesia, they preserve the cell-mediated immunity, unchanged angiogenesis, maintains the apoptotic phenomena, and hence they promotes the control of minimal residual disease and hence lesser chances of recurrence or metastasis. On the other hand, the volatile-based general anesthesia technique, the use of inhalation agents, the use of opiate analgesics, the impact on the neuroendocrine stress response, they all impairs the cell-mediated immunity with increased angiogenesis, and probably this appears to promote the cell recurrence in patients undergoing surgical procedure under general anesthesia. So this is one aspect when we talk about the various cancer biology with regards to the technique and drugs that we use. Simultaneously, we also need to look for other factors which can affect the cancer biology. And there are many factors, right? The anemia, the perioperative blood loss, the thrombotic phenomena. So these are all related to the oncology outcomes and they also have impact. Even the anemia, which causes certain changes, the need of blood transfusion is also associated. So probably it has some effect on the immune modulatory effect, and that can lead to the inhibition of the cancer protective mechanism. And the studies are coming up where they mentioned labs are higher in those patients who are in the perioperative period, and their outcome is more as to those patients in which those were not receive any blood transfusion. To be a little cautious with regards to these aspects. The second aspect, we also need to understand biologies with regards to thrombosis is of various thrombosis. We know that cancer thrombosis, cancer and thrombosis are they have impact applicable for these group of patients. In case chance of, if we look for various factors, we know that the older is associated common, but we also need to understand that certain pathologies are more associated. They will be releasing certain factors procoagulant, and hence the chance much higher. The much commonly seen adenocarcinoma patients, and hence the chances of will be much higher. The risk of much higher in patients like hematologic and stomach, and they're lesser in breast and prostate. This means these tumor on and embolism is also seen and dependence upon various cell pathology. And this can be further influenced by when we talk about the external factors, which we have earlier discussed about the chemotherapeutic agents and other aspects of the perioperative. So to summarize what I mentioned in last couple of slides, we have certain factors which influence the cancer biology. There are certain which promotes the cancer proliferation, metastasis, and recurrence, which is further enhanced by the phenomena of immune suppression, angiogenesis. And there are certain factors which inhibit them, and they appears to be protected. Though we don't have a robust data to confirm that this is the protective mechanism, but the directionality of the protective mechanism versus promoting mechanism has been shown in various in vitro studies. And some of the observation data are coming is in direction, and we can start using a perioperative care so that we can improve the outcome of these patients much better. We need to have a personalized perioperative plan for these patients, considering the cancer biology. We need to modify the inflammatory burden, which is one of the important predecessor for recurrence. We need to understand the effect of drugs. Probably in future, some amount of pharmacogenomics will help us to decide that which is the best drug for these patients, for this cancer biology, so that the chances of recovery is best and recurrence is less. And this will probably affect us, the functional recovery of these patients by all these phenomena. So to summarize, cancer biology understanding is important to understand cancer presentation and its prognostication. Cancer time sensitive, offering limited scope for optimization. We need to use them judiciously and timely. Preoperative assessment should be based on time and extent of procedure, physiological perturbations due to the cancer itself or the functional status or tumor characteristics. In-depth understanding of the cancer biology and its diagnosis and its impact of various therapies, including chemo, immuno, radiotherapy, should be understood. And anaesthetic technique that has a possible impact on cancer outcome requires further evidence. But whatever we are available with, we need to make a strategy to use more of a protective mechanism, protective strategy, so that we can provide best possible care to our patients. Thank you so much, and we are open for comments or anything we can add on.
Thank you, Rakesh, for a beautiful and elaborate talk covering almost every points, every issues. So is there any questions from the audience, from the delegates?
Good evening, ma'am. Can we
Yeah.
ask like this, or should we?
Yeah, sure. You ask me, Abdi.
Okay. Thank you for the wonderful presentation, Dr. Rakesh. I think you've really very comprehensively covered all the aspects of cancer biology. So you mentioned that regional anesthesia has its advantages with respect to various factors in terms of cancer progression. I mean, the entire thought process works well, mainly when we look at cellular studies, but the only biggest randomized control trial that was done by Dr. Daniel Sessler and published in Lancet in 2019 somehow did not show any effect on the regional the advantage of regional anesthesia versus general anesthesia. So what are your thoughts regarding this?
Right. So you're absolutely right, ma'am. So when it was all hypothesized around 10 to 12 years back, it was more of a hypothetical situation. And then subsequently some data was coming up. So I mentioned that the protective mechanism is not well proven. There are many studies which are going up with follow-up studies. The data is yet to come up. But if you see the whole data, we can only say the directionality of the protective mechanism is seen. We don't have evidence to say that it is protective, but it appears that probably it is better. It may be protective, but if we understand the physiological phenomena and the cancer biology as such, we are using regional blocks. So that's why the continuity of combination of general anesthesia plus regional anesthesia, giving up the basic, you can say, strategy that to suppress the stress response, to avoid the hypoxic milieu, to use the drugs which is anti-inflammatory, having an anti-inflammatory cascade. I think these are the well-accepted norms, and they are all being provided by regional anesthesia as compared to general anesthesia. So we can continue with this. Probably we need to look for more data to come in future to confirm that one particular technique, a strategy, or a drug is protective or they are neutral.
Sure, thank you. I agree. I mean, it is not definitely inferior to general anesthesia, and maybe, like you said, because of other advantages, those who prefer doing regional anesthesia techniques in these patients can continue doing it. I completely agree with you. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Rakesh. That was an excellent presentation. A lot of clarity about the issues. would you say, in continuation with the previous question, because you use regional anesthesia, that sort of brings down the doses of the other agents that we use. So perhaps that itself is protective?
Maybe, well, yes, we can say, because we usually talk about balanced anesthesia, balanced analgesia technique. So each drug will have some influence on the cancer biology. We know that certain drugs, like for example, lignocaine has an anti-inflammatory action. We know that morphine has some effect on the suppression of some of the cells. So probably when we try to balance it, like for example, in one of the studies they mentioned that midazolam has a protective mechanism, but at much higher dosages. Similarly, morphine has an potential to cause cancer recurrence, but probably it may be at much higher dosages we want to use regularly when we provide a balanced anesthesia, balanced analgesia techniques to our patient. So probably it appears that once we start using the combination of techniques, the drug dose of various drugs which are being used isolatedly with a single technique comes down, and they will have a balanced effect, a positive outcome, favorable outcome with regards to the cancer patients. Probably that needs to be come up in near future, that which drug, which dose is protected.
Thank you, Dr. Rakesh. I also think there's a lot of, there's a complex interplay between, as you said, the physiological and pathological mechanisms and the pharmac that occurs. So it's a little unpredictable, I think, at the moment.
Yes,
Maybe, yeah, later we'll have more evidence. Thank you.
there are many big studies going on in various places. So I hope it will take a couple of time, because this all started around 10 to 12 years back, and that's the hypothesis. So we don't have a long-term follow-up data for majority of these patients. So I think near future we'll have some concrete data which is coming up, and that will give us some direction that what should be our perioperative strategy for a cancer patient management.
Thank you.
Good evening, sir. I'm Dr. Indira. Sir, what is the effect of nitrous oxide, sir? I know that we have come down on the use of nitrous oxide, but what is the...
So, nitrous oxide, there are not many studies, but I remember, I think 1 or 2 studies I have read somewhere that they have a suppressive effect on those protective mechanism, NK killer cells and all those phenomena. So probably if it has a suppressive action, probably there will be metastatic potential. So that is one phenomenon that has been seen, and some of the studies, there is not many evidence to my knowledge, but it is more favorable to the occurrence of cancer. But on the other hand, if we talk about, we know that nitrous oxide is a good analgesic agent also. But as we were discussing earlier, rather than using nitrous oxide as a potential for providing analgesia, we can always use regional anesthesia now, which provides better analgesia as compared to the techniques we are using with general anesthesia.
Okay, sir. Thank you.
I think can I just say something?
Yeah,
Sorry.
go on,
I
go on.
think when we deal with a patient as it is, we just cannot just see whether the cancer recurrence, because the latest post hoc analysis of use of nitrous, the Enigma 2 trial is suggesting that not only, it has got effect in doesn't cause atelectasis and post-operative infection. Nitrous is actually, use of nitrous is considered better in post hoc analysis as contrast to, Enigma 1 trial. So I guess that each and every patient we have to deal according to our clinical judgment as well, rather than we can be compartmentalizing our knowledge into what we exactly need to do and what we absolutely don't need to do. That's what I feel.
Thank you, ma'am. Actually, I had read somewhere that it has, we all know that it has some myelosuppression effect and on the vitamin B12.
Yes, absolutely. The report says that it is a very early report. Yes, absolutely. It says that it has got a suppressive effect on bone marrow. But again, I think the studies about what should be the concentration, how many hours of exposure, those studies are still not being done, because it is so difficult to actually get proper patients and then plan a proper study. So yes, initial molecular biology level, it suggests that it suppresses, but exactly to what extent, what concentration, those things are still, I think, in the gray zone.
And also there's some doubt about its effect on the amino acid metabolism also. So I was just wondering, maybe there is some effect of nitrous oxide on cancer patients. So
Mhm. Dr. Ram.
Rakesh, I just want to know, suppose we all know the stress causes, increases the recurrence and everything. So we try to, all the measures are being taken to reduce the stress, surgery-related stress. So do you suggest any particular marker? There are many markers to find out the stress, how far it is, our intervention is effective or not. So any particular one marker or few markers which you suggest, if suppose to do any research work, whoever is wants to do, which marker should be seen into?
People have used various markers, ma'am, and mostly most of them are for research purpose, like initially the steroid levels, the glycemic control, and more recently people are doing more of an NLR analysis in the post-operative NLR calculation, neutrophil lymphocyte ratios in these patients, which are suggestive of the stress response in these patients. And then in addition to it, people are looking for the biochemical markers, the inflammatory markers, interleukin, cytokines, to look for the response, the stress response these patients will manifest. And they are simultaneously looking for whether they will have some suppressive action of a particular technique. But these mostly are for the research purpose. To my knowledge, there is nothing called that this marker is applicable, should be done intraoperatively, and this will show us the that this patient is under stress or not. That's why we need to provide them a good analgesia, as Madam was also saying, that we have to individualize the care according to the patient's physiology, so that we are providing them the best perioperative analgesic management, best fluid management, not creating an hypoxic milieu. So this balanced anesthesia probably will take care. In this balanced anesthesia, what combinations we use is yet debatable. Time will tell us that it will be an opiate-based analgesic technique or a regional-based, but yes, that needs to be taken further.
So actually, whatever we are using presently, whatever all of us are actually doing present with balanced technique, along with general anesthesia plus regional anesthesia and opioid in whatever dose, not the maximum dose. So opioid sparing technique. So all those things, I think, whatever is doing, depending on our outcome and all, I think it should be continued, because there's no robust evidence to change our practice or something. What do you think?
Dr. Vibhaj mentioned about the study which is recently published from the Tata Hospital, a multi-centric study, where he mentioned about the use of the wound catheters for the breast surgical procedures.
Yeah. No. I'll just, sorry. So actually, Dr. Badwe from Tata had this multicentric study where I think most of our hospitals, even yours, AIMS, all of us have participated. It's a surgeon-initiated study where they actually infiltrated lignocaine, 0.5%, into the 4 quadrants of breast after they removed the tumor. And they have found that local presence of lignocaine reduced recurrence. They have actually followed them up, I think, for a few years, at least 2 years or maybe 5 years, and they have found out that it has reduced recurrence. So I'm just thinking, if local lignocaine helps, should we consider wound catheters, particularly for breast cancer surgeries, is what my thought process was.
Vibha, can I answer this question if Dr. Rakesh doesn't mind?
Yeah, absolutely, ma'am, absolutely.
Okay. So actually, there is a very big meta-analysis that was published, I think, 2 or 3 months before in Canadian Journal of Anesthesia, where they took a huge number of patients in which local anesthetic in any form, whether you give local infiltration, whether you put wound catheters, whether you give PEX block, whether you give paravertebral block, any form of local infiltration, anesthetic infiltration after the post-surgery, post-breast cancer surgery has actually demonstrated significant reduction in the recurrence. I don't exactly remember the number of the patients, but it was close to 2,500. I have to check again. But they have said clearly that any sort of local anesthetic, whatever you are comfortable, the surgeon is comfortable, your institutional practice, but we must have the habit of inculcating or injecting some sort of local anesthetic after the breast surgery, whatever your institution says. So that is the meta-analysis that they have done, and they have come to this conclusion.
So I think same phenomena, if you see, ma'am, the newer facial plane blocks which are coming up, so they are also infiltrating in the same plane blocks, because what we want is two effects. One is local effect and second is systemic effect. So this type of infiltration is affecting both, because now we have studies where they have used intravenous lignocaine infusion and they are looking for those outcomes. Probably again, the directionality says that it appears to be protective, but I agree with both of you that probably the route that you are using it, because if you infiltrate in a surgical area with good amount of or good volume of this lignocaine, the systemic absorption is definitely there, because the area is inflamed, the vascular permeability is increased. That's why the absorption will be there. So we do not know exactly that it is having a local effect or a systemic effect. But finally, if you see the biology which I showed in one of my picture, probably it has a multi effect on the multiple aspects. So infiltration or using a facial plane blocks, using catheters, I think we can choose for anything. But I just want to highlight that putting catheters in surgical procedures like breast is not advocated, because they are becoming more of a daycare procedures. And once you start putting up catheters, if you follow the RAS protocols where we say no catheters, then we are going against that. So I think we need to look for procedures which are more of a daycare, vis-a-vis those procedures which are admitted into our hospital, and we can put in catheters for anything. But the RAS protocol says no catheters, it should be patient ambulation and other techniques should be used. I think we need more evidence to suggest it, but yes, use of local anesthetic agents by whatever we are discussing, infiltration, intravenous administration, local infiltration or catheter-based infiltration, I think they appears to be protective. We do not know whether they have a systemic effect or they obtain the inflammatory response, the stress response, better analgesia, or a systemic effect.
So I just wanted to add one more point, sir. It's about the use of statins in cancer recurrence. So there is a lot of recent literature, isn't it, regarding the protective effect of statins in cancer recurrence?
I think I do not know. There are multiple evidence. I think I have seen one or two papers regarding statins, and they were not very reassuring. They appears to be protective, but they're not reassuring. So to my knowledge, I'm just aware of one or two papers I've read. If somebody has read more papers or more information, please add on.
Okay, any more questions? If no question, then we can close it now today, Rakesh.
Yeah, sure, ma'am. We'll follow instructions.
So, good. It's a very comprehensive talk. We have discussed nicely. I think no more discussion, no more question I can see in the chat box. So we'll call it a day. Thank you very much. Thank you all of you who have attended this, and sorry again for the initial glitches, for the technical glitches. Thank you all.
I want to say something. First of all, we are very sorry for the unintentional inconvenience, and thank you all for cooperating with us. And thank you again, Rakesh sir, for your sharing valuable insights with us. We are more than grateful to everyone present here. We hope to have you again with the session. With all your permission, can we conclude the session over here?
Yes, thank you.
Okay.
Yeah, thank you, ma'am. Thank you so much. Thank you, everybody.
Thank you, sir. Good night.